Hello and welcome to this presentation on acute kidney injury or AKI. So what is an AKI? An acute kidney injury is an abrupt decline in renal function that is defined by an increase in serum creatinine or decrease in urine output. It can be classified as stage 1, 2 or 3, with stage 1 being the least severe but most common and stage 3 the most severe but least common. Each stage is defined by changes from a patient's baseline creatinine, with stage 1 an increase of 1 to 1.9 times the baseline, stage 2 an increase of 2 to 2.9 times the baseline, and stage 3 an increase greater than 3 times the baseline or the need for dialysis. Many hospitals will have an electronic alert flagging patients with an AKI when you are looking at blood results. So why is an AKI important? To put it simply, if your patient has an AKI, they're at increased risk of dying. In fact, if they have an uncomplicated AKI, the chance of dying is as high as 10%, with this rising to 80% in the context of multi-organ failure requiring dialysis. It is therefore obvious why we need to try and prevent AKI in the first place and recognise really early when it does occur. There are lots of people in the community and in hospital who can develop an AKI. Are we able to identify those most at risk? The answer is yes, and recognising these patients is an essential part of preventing it. So who's at risk? There are a collection of pre-existing factors that increase risk, such as being older, having chronic kidney disease, diabetes, heart failure, liver disease, and peripheral vascular disease. It is also recognised that 20% of patients admitted to hospital develop an AKI, with the risk being higher in those with more pre-existing conditions. Now let's look at what can happen to someone to trigger an AKI. Some common triggers include hypotension, hypovolemia or reduced circulating volume, sepsis, deteriorating early warning score, undergoing surgery and using contrast in scans and angiography. If your patient has any of these triggers or pre-existing conditions, certain medicines can make things worse, and it would be best for your patient if they were avoided. The drugs you need to be aware of include ACE inhibitors, angiotensin receptor blockers, non-steroidal anti-inflammatories, metformin and gentamicin. And remember, if your patient has had an episode of AKI in the past, they're at higher risk of getting another. Since we know what an AKI is and who is at risk, let's talk about the causes. The easiest way of thinking about this is to classify the causes into pre-renal, renal and post-renal. So let's look at each of these in turn. Pre-renal AKI occurs when there is reduced blood flow into the kidney. This is usually caused by dehydration, bleeding, or infection. This reduced flow causes damage to the kidney, which, if identified promptly, is reversible. Moving on to renal AKI. The kidney is a complex organ that functions to actively filter the blood. There are several conditions that cause the kidney to become inflamed, and these include glomerulonephritis, vasculitis, and interstitial nephritis. These conditions are quite complex, and there are rarer ones that I've not even mentioned, but to the non-nephrologist, the important part is in the recognition. And this is why us kidney doctors love pee and what it tells us. You see, as the kidneys become inflamed, they also become leaky, allowing blood and protein to escape into the urine, which can be detected on a simple urinalysis. And finally, post-renal AKI, which, as the name suggests, is caused by obstruction to the flow of urine once it leaves the kidney. The commonest causes of this are compression from tumours, kidney stones, or prostate enlargement. Although renal doctors may need to be involved in severe cases of post-renal AKI, usually the urology team are required to sort out the problem. Now, let's look at how we diagnose an AKI. There are some key questions which can help to point you in the right direction. These include asking your patient about any diarrhoea, vomiting, poor oral intake or bleeding. It is also important to think about infection. Non-specific symptoms such as rash, joint pain and weight loss can indicate a renal cause for the AKI. It is also really important to ask about recent changes in medication and problems passing urine. The next step is to examine the patient. Firstly, you need to assess fluid status. Blood pressure and heart rate are really important here. A low blood pressure with or without a high pulse rate may indicate hypovolemia. But, as with most of medicine, fluid assessment is a bit of a jigsaw puzzle. You therefore need to look elsewhere for clues. This includes looking at mucous membranes and the jugular venous pressure. If the JVP is not visible, it is likely that your patient might be dry and require more fluids. But if it is raised, it is likely that the patient has lots of fluid on board. Other signs that may also suggest that the patient has too much fluid on board include peripheral edema and crackles on listening to the back of the chest. The rash that we are interested in is usually found in the legs. It is a non-blanching purpuric rash, which means it is deep red in colour and does not disappear when you press it. It is important to look for it as it can be a sign of vasculitis. Remember post-renal AKI? Well, if you can feel a swelling or mass where the bladder should be and the patient has an AKI, it is likely to be post-renal. If this is the case, you should put in a catheter, even before the ultrasound scan is done, because the longer an obstruction is left, the worse the kidney damage will become. After taking a history and examining the patient, the next thing you need to review is their medication. The two essential things you have to do here are, firstly, you need to stop any drugs that can worsen things, such as the drugs we mentioned earlier. These are ACE inhibitors, angiotensin receptor blockers, non-steroidal anti-inflammatories, metformin, and gentamicin. Also, if your patient has low blood pressure, remember and stop their antihypertensives. Secondly, make sure that all drugs are prescribed at an appropriate dose for the patient's renal function. So, once you've discovered your patient has an AKI and stopped any harmful drugs, you need to think about what tests you need to do. The blood tests you need to request for all patients are hemoglobin, bicarbonate, calcium and phosphate. If sepsis is suspected, remember to check CRP, lactate and cultures as appropriate. As well as having blood tests, all patients must have their urine dipped, as we talked about before. If there is evidence of blood and/or protein, then you should request immunology tests. These are ANCA, ANA, immunoglobulins and complement. If there is protein present, we need to know how much. To find this out, you can send a urine protein to creatinine ratio, otherwise known as a UPCR. So that leaves the myeloma screen to think about. This should be carried out in any patient over the age of 50 who is found to have anemia and hypercalcemia on initial investigation. A myeloma screen involves sending a urine sample for Bence-Jones protein and blood for protein electrophoresis. So, what about the renal ultrasound scan? Obviously, anyone with a suspected obstructive cause needs an urgent ultrasound scan, but they may also be useful in other cases. Here comes one of the most important bits. How do we manage AKI? Well, most importantly, if your examination findings suggest that your patient is hypovolemic, you need to make sure that they are adequately fluid resuscitated and that accurate fluid balance measurements are taken. We would suggest using 250 ml boluses of crystalloid for fluid resuscitation, making sure you reassess after each bolus and seek senior help when you've used 1 litre of fluid and no response has been seen. Along with giving fluids to those who need them, other simple interventions that will help the majority of AKI get better are stopping any high-risk medicines, avoiding contrast, and by treating whatever has made the patient sick in the first place. If it is sepsis that is making your patient sick, prompt antibiotics should be given, but remember to avoid gentamicin. If this isn't the case, then when should you get the renal team's help? In Tayside, it is important to know that we are always happy to advise, but there are patients that we definitely want to know about. These include anyone who has a stage 3 AKI, or known to have stage 4 or 5 chronic kidney disease, anyone who's had a renal transplant, also anyone with a potassium greater than 6.5, resistant pulmonary edema, and continued oliguria or deterioration despite treatment. And finally, anyone you think might have a renal cause for their AKI. For example, patients with blood and protein on urinalysis without a UTI. For these patients, it doesn't matter how good or bad their kidney function is, we need to know about them. So that has been a whistle-stop tour of AKI. Thank you for listening, and we hope that you've found this useful.